afternoon session, Masters Talk Cataract session 9. So we'll start in the right earnest. Safe quality SICS in 2 minutes. Dr. Rakesh, please. So I welcome Dr. Rajendra Prasad, who is the chairperson, and other speakers, Dr. Vanathi, and the 4 listeners we have.
So, good afternoon, respected chairperson and dear friends. And I'm going to present a safe quality SICS in 2 minutes. So, in our country, there is a large population where the unmet need of the cataract surgery is very high. So, it demands a cost-effective, fast and reliable method. So, M6 provides the most benefit of phaco at the reasonable cost and limited time. In developing country like ours, there is the shortage of human resources, infrastructure, funds for the surgery. So, I am going to a small video. This is the unedited video. Initially, I make a side port and put the visco and deepen the chamber. And after that, tighten the bridle suture. And then after doing the conjunctival peritomy, and there is no need of the cautery, and then make a front-save incision is about 1.5 away from the limbus. And with the help of the crescent, this incision is advanced into the cornea, it is only 1 mm. And then AC entry done by the keratome and cut up to the side port. And with the help of the atrata forceps, we make a rhexis. And hydrodissection done, and nucleus plus with the help of this hydrocannula into the antechamber, and put the visco behind the lens and then dilute with the help of the Bayer-Vectis technique, irrigating Bayer-Vectis. And the cortical removal done with the help of the Simcoe, and then I always do the hydroimplantation of the IL. So as you see, this surgery actually completed in the less than 2 minutes. So the cataract surgery not an emergency surgery. So why to do it fast? So as you know, the blind people in India is 9 to 12 million, and the blindness due to the cataract is the 50 to 80%. So the 3.8 million actually added every year. So as you see, this is the huge cataract backlog when we are actually in the camp area, and the patient waiting to get operated. So you can see our actually this is the OT list. Actually, you see this is the winter season. It is the 1200 actually people as in the one day. These people are admitted for the cataract surgery. So these actually data signify the need for the safe, affordable and slightly fast cataract surgery in the developing country with limited resource and large population. So actually our day start with the responsibility, and this is the teamwork, not a single person. And so how to develop this surgical technique for SICS 2 to 5 minutes. So this is the good surgical technique and fixed surgical steps. And so we do the fast and safe quality SICS in 2 minutes. So these are the steps actually. Pre-operative draping is done by the assistant, and first we make a side port, and then standing with the entry capsule with the trypan blue and visco injected to deepen the chamber, and after that the superior conjunctival peritomy done. And the front-shaped incision is about 6 to 6.5 mm sized, and it is 1.5 away from the limbus. And it is the partial thickness scleral tunnel is extending into the clear cornea, and antechamber is entered with the 3.2 keratome. And then after that, with the help of the Uttarata forceps, we make a circular axis. So these are the slightly complicated, these challenging cases require the slightly more time. And after that, we hydrodissection is done, nucleus prolapse into the antechamber, because this is the much hydrodissection not required in this type of cases. And put the visco anterior and behind the lens, and then deliver with the irrigating bacteria. So after that, the cataract cortical removal done. In the actually hypermature cataract, sometimes the cataract is very sticky, so it requires slightly more time, and then polished with the help of this Simcoe cannula. Despite of that, sometimes the cortex actually not properly removed from the area, but the central part is clear. And hydroimplantation done. So this is the learning is the continued process. So we have the bait lab training, and also, and that we have the 26 modular OT theater, and we have the about the 150 doctors in the Sadhguru Nechakshale Chitrakoot. So we can in the winter season we can do approximately 800 to 1000 operations per day. And you can see the 5-year data. We are actually performed 100,000 cataract surgery per year. So our vision, our actually mission is the service to humanity, food for hungry, and cloth for the destitute, and sight for the blind. Thank you so much.
Thank you, Dr. Rakesh. It's amazing you are doing it in less than 2 minutes, and it's a great service to the community and the country which you people are doing. Thank you.
Thank you, sir. Thank you.
So, can we go ahead with the next presentation by Dr. Ashok Nanda? Tips and tricks for perfecting capsular access.
Okay, good afternoon, everybody. We know that in 1970s, capsulotomies were many, starting from Christmas tree type of capsulotomy to can opener. But CCC was a stepping stone where the outcome of cataract surgery were actually transformed. So this credit goes to 3 surgeons, Howard Gimbel, Kimiya Shimizu, and Thomas Newhan. So the 3 surgeons were operating the similar technique in 1980s at 3 different parts of the world, and from their terms that they used, the first term was taken up to give this word called continuous curvilinear capsular axis. So why should you do a CCC? It prevents extension of a capsular opening during intracameral manipulations. It helps in the black bag placement of the intraocular lens so that the lens remains centered. It prevents PCO by proper superimposition of the rhexis margin on the lens, and it can act as a scaffold in case of a PCR. To learn CCC, it has to be through 2 or 3 steps. The first is to learn about the normal steps then you have to master it and go into difficult scenarios. To make a normal CCC, you have to understand what is the difference between a tearing and a shearing force. We know tearing force is when you apply the force to tear a capsule 90 degree to the direction of the tear, whereas if you make it parallel to the direction of the tear that you desire, it is shearing force, and that is how a normal CCC should be performed, by folding the flap on itself and then pulling it along the direction or parallel to the direction where you want it to be. So in these videos, you can see that the chamber has to be filled with viscoelastic, and the entry capsule should be made flap. You can use a capsulorhexis forceps, Atata forceps, or a cystitome to cut and then fold the flap and gradually keep on pulling it along the direction of the desired side and complete the rhexis. So the first step is that you must complete the rhexis, not bother about the shape or the size of it. Using trypan blue is helpful in mature cataracts. Then once you know how to do a complete CCC, then you have to think about making it the right size. So the easiest way is to measure a 5 millimeter diameter with a caliper and center it, put the marks with the Purkinje reflex in the center, and then do the rhexis and follow those marks. So that will roughly give you a 5 millimeter circular rhexis. If you have a rhexis marker, that's still better. The rhexis marker has a central hole, and you must see the Purkinje reflex in the center and then put the mark. So it gives you a nice circular 5 millimeter mark on the cornea. Then you can, of course, follow that mark and convert your rhexis circularly. Make sure that you are following that mark which is there on the cornea, and it is usually parallel to your pupil which is dilated. And of course, if you have a marking imaging system, then of course that is you can modify the size, the area where you want to make the rhexis, whether you want to make it central or off center. So all these can be designed and you can complete your rhexis. So this is how you can master your rhexis and make it more perfect to the size you desire. Now let's come to some situations where you have to be a little more tricky. In a mature cataract, the first thing is that you must stain the capsule with trypan blue. You cannot see the capsule unless you stain it. And then use a high molecular viscoelastic. And in mature cataracts, normally the interlenticular pressure is not very high and the fluid cortex is not there. So naturally you can plan a rhexis of the desired size of 5 or 5.5 millimeter and complete it. But in a case of intumescent cataract, the situation is a little more difficult. You have to again stain it and plan for a smaller rhexis, size somewhere around 3 to 4 millimeter, and subsequently expand, but make sure that the chamber is never shallows. It has to be repeatedly filled up with viscoelastics so that you can complete the rhexis. And in a case of Morgagnonian cataract, once you puncture, the fluid cortex leaks out. So make sure that you are aspirating out the fluid cortex. Once the fluid cortex is aspirated, refill the antechamber with viscoelastics and continue the rhexis. In a case of pediatric cataract, this is a little more challenging because the capsule is more stressed here, the zonules are stronger, and it is more elastic. So you plan for a size lesser than what you desire. So if you plan a 5 millimeter rhexis, try to keep it somewhere around 3.5 to 4. It will automatically stress to become a 5 millimeter rhexis. Now, if you, in a small pupil also, if a size is around 4.5 to 5 millimeter, you can follow the pupillary margin as a marker to make the size somewhere around 5 millimeter. If it is smaller than 4 millimeter, you have to obviously use hooks and dilate the pupil and do the rhexis. Suppose while doing the rhexis, you land up into a complication. The most common complication is rhexis run out. So in those cases, you have to have certain equipments at hand to complete it. You must have a micro-rhexis forceps and also micro scissors. So make sure in intumescent cataracts that you have filled up the antechamber tightly with high molecular viscoelastics and keep filling it during surgery. And in case, in spite of doing everything, you still land up into a capsular tear, in that case, you have to have a side port and cut from the side and extend the rexis. After you complete the rexis, because it is already extended, you have to use lower parameters to complete the phaco, of course. In a subluxural cataract is still more difficult. You have to first bring the lens to the center. So start the rexis from the dislocated side and then use hooks to pull it to the center and complete your rexis. So to summarize, practice rexis in a good dilated pupil. Use trichome blue. Always keep the antechamber deep. Use high molecular weight viscoelastics. Keep micro rexis forceps and micro scissors ready, and only practice, practice, and practice can make you do a good rexis. Thank you.
Thank you, sir, for elaborating on various ways of doing capsular access and difficulties encountered. Any questions?
Very nice presentation, Dr. Akshuk, and beautifully explained each and every part of the capsular axis, because this is one of the very important steps. If your axis is correct and if you have completed axis according to your need, especially the size and shape and the circularity of the axis, then the further process becomes very easy. So very nicely explained. Thank you very much. Thank you. Dr. Chaudhary, you want to speak?
Explain actually, if you have to have a patient who has a lot of anticapsular fibrosis, either you go around that, which is sometimes possible, otherwise you have to have micro scissors and keep cutting through multiple side ports. So you can make 5 to 6 side ports and keep cutting with the micro scissors. That should be fine, because they are tough capsules, they will not extend even if the margins are not continuous.
True. So some micro scissors you cut it around. Sometimes micro scissors also is unable to cut it at time. Then I saw one presentation where they used a phaco cutter and they kept cutting it till they made the whole curvature equal to 5 millimeter that they wanted. That came out very well. Just a additional point.
Thank you very much. Thank you, Dr. Chaudhary. Okay, now I'll call upon Dr. Gopal Pillai. Dr. Gopal is going to talk on retinal complications of cataract surgery. Dr. Gopal, yes.
Thank you very much, sir. Thank you very much, madams. Thank you very much, all the other speakers, for letting me do. So retinal complications usually come as the last topic, and it is nice that I have some people to hear that now. At least I see it only after it is occurring, but at least other people who do a lot of cataract surgery definitely should be doing that. So let's start up and say there will be some block-related complications, vascular blocks, suprachoroidal hemorrhage. Yes, it is a very, very problematic thing. Light toxicity, nucleus and eye oil drop, cystoid macular edema, and endophthalmitis. Local anesthesia related, if you are looking at it, like this is a needle which you are blindly inserting through the side of the globe, and anything and everything can happen. Usually the first year PG is the person who does that. So there are 3 clinical situations. One clinical situation is that, the astute clinician in the PG or whoever is giving the block, found out that the needle is inside the globe, understood that it is inside the globe, and immediately took it out. Okay, that is the first situation. The second situation is the person injected inside the globe, didn't realize that it is inside the globe, and injected the block, whatever, inside the globe itself. Okay. Number 3 situation is even more tricky. You went inside, and then you went outside also, and in the correct plane you injected. So these 3 situations are there. Now let us see how each would present. The first situation would present like, there would be a perforation, and then if you are careful, there may be a subconjunctival hemorrhage there. And usually when the needle is going in, there is going to be severe pain when the sclera is getting perforated. Now the second situation is a little troublesome, because if you inject the block, whatever it is, inside the eye, then the pressure will immediately shoot up and the cornea will become steamy white. Immediately there will be corneal edema which will be coming in. And the patient will have intense, severe pain, and the cornea will become immediately white. Number 3, nobody knows I mean, neither the person who gave the block, neither the patient, nor the surgeon will know, and the surgeon will complete the phaco. And post-operatively, I mean, intraoperatively, if you give a massage or something like that, there can be a hypotony. But otherwise, you will not even know, and you may consider doing the surgery, go ahead, and after that, finally, you may end up with a retinal detachment later or a vitreous hemorrhage later. These are the three situations. Now, this after perforation, pre-retinal blood and vitreous hemorrhage was there in this particular case with a retinal localized retinal detachment was there, and we did a vitrectomy with fluid air exchange and silicone oil. So this is a very, very good prognosis. Immediately, if you do, yes, if there is a percolating subretinal hemorrhage which has moved into the macula or something like that, yes, then there is a bad prognosis. Otherwise, this is very, very good prognosis. Now, this is a patient in whom there was this lid damage, okay, and somebody gave a little local anesthesia there, but because there is a little bit of scarring, the needle inadvertently, because of the force, went inside and went inside. Now, this is a telltale sign. You can see this air bubble is a telltale sign that you have actually perforated, because you can have air bubble inside the eye only after perforation, right? Now, this patient came to me with complete loss of vision to almost PL plus, and when I looked at it, the optic nerve was slightly pale, I mean, there was nothing much, like 57 seconds was the, this was the arterial and venous filling. So there was no central retinal artery occlusion. There was no significant optic nerve damage. So I was like, patient's vision is PL. Probably it's like because the pressure that the patient was injected with that block inside the globe. So probably that pressure caused a functional optic nerve damage. And 24 hours down the line, I had given an IV methylprednisolone actually, and 24 hours down the line, this patient improved to 6/6. Now, if there is a break, now what should we do if there is a perforation? Definitely you should do an indirect ophthalmoscopy. That's a natural next thing. So if you do an indirect ophthalmoscopy, and if there is a tear which is found, and if you have a possibility of doing a cryo or laser then and there, that's, you can seal the deal there. If VR support is not available, and then conservative treatment, you can basically slowly refer the patient. But I don't think, unless the cataract is very hard and the visibility to the retina is absolutely not there, I think we should defer the surgery of that particular patient. So steroid antibiotic cycloplegia can probably refer to a VR surgeon. Now this is again another patient who had been operated for LASIK, high myopic patient. This is a patient like the third situation. This patient came with a late retinal detachment. Probably there was a perforation in, perforation out, and the surgeon did not know, neither the person who gave the block knew. And there is a late onset retinal detachment, and we had operated, and finally visual acuity was very good. Now, whenever the pressure inside the eye increases, especially in optic nerves which are quite labile as in advanced glaucoma, or sometimes in diabetic discs, there could be, or if there is a retrobulbar hemorrhage, or if you massage too much, or you apply a balloon or a pinky or something like that, then you may have a central retinal artery occlusion or a venous occlusion in those patients. Now, you know, central retinal vein occlusion and BRVOs, all of them, usually you have to find out how much is the edema and generally consider injection, etc. Now, central retinal artery occlusion will have these cherry red spots, and the vessels would be like cattle trucking will be there. So these signify that there was a very, very high pressure during surgery. All right. Now, expulsive hemorrhage. Expulsive hemorrhage is a rare problem, but very, very serious. And less seen now with the smaller incisions and the phaco incisions that we have. It is very, very less seen. Sudden increase of IOP will be there, and there will be darkening of the glow, and wound gape and iris prolapse with expulsion. And close wound immediately with digital pressure or sutures is what is to be done. Sometimes you can do a posterior sclerotomy and allow the escape of the suprachoroidal blood. Light toxicity sometimes occurs if you are a novice surgeon studying a new technique, taking more time. Then generally this light toxicity will come. There may be some cystoid macular edema or RP burn which will be there. Choroidal detachment, if there is a hypotony post-operatively, if there is a wound leak post-operatively, there could be a choroidal detachment which can come up, and then that will induce more hypotony, and hypotony will induce choroidal detachment, and that vicious cycle may go on. To break it, probably you'll have to increase the steroid dosage and do that. Okay, now this is a choroidal detachment. Ischemic optic neuropathy. Sometimes what happens in phaco, people keep bottle very high, and in susceptible optic discs, you can have an intraoperative AIOM. and I had published a series of 7 cases of intraoperative AION following phacoemulsification. So the incidence is quite not so common, but if there is AION in one eye, then the other eye is very highly likely. This is an anterior ischemic optic neuropathy. You can see the one side there is a pale disc edema, and other side there is telangiectasia. Okay. Vitreous hemorrhage, any blood in the anterior segment can just go into a posterior segment if there is a PC rent. So that's if there is a PC rent, please make sure that there is no blood in the anterior chamber like that. Mild hemorrhage you can observe. If there is massive hemorrhage, you can do a vitrectomy. Now this is you can see that this is a nucleus drop. Oops, the video is not running. It's okay. Nucleus drop is managed by, generally I would ask all my friends to put up lens immediately even after the nucleus drop is there. Clean the anterior segment up, put a lens on the sulcus. Generally if you want a multi-piece IOL, 3-piece IOL on the sulcus. And generally now 23 gauge phaco-fragmenters are available. Call your vitreoretinal friend. Please have a vitreoretinal friend, okay? So call a vitreoretinal friend and tell him that there is a nucleus drop, so he will advise, and based on that you manage it then and there, because all these patient hanky-panky, let's avoid all that. So dislocated nuclear fragment or lens matter can cause high intraocular pressure, and that high intraocular pressure and uveitis can be managed like that. IOL can also be dropped. This is an ultrasound of the posterior dislocated lens, etc., etc. Cystoid macular edema usually occurs later. Yeah, let's stop.
No, please wind up.
Okay. So cystoid macular edema and endophthalmitis. These are two terrible complications. Cystoid macular edema is still all right. You can manage with NSAIDs and then posterior subtenon. Endophthalmitis has to be managed as early as possible with an intravitreal injection, or if the vision drops, with vitrectomy. Thank you very much.
Thank you.
One, how much pressure in the eye induces AION?
So it's very variable, sir.
CR?
Yeah. So the venous, the arterial pressure of the central artery, central retinal artery is about 35 to 40. Okay, so that is a pressure with which blood is coming into the eye. And the pressure system of the venous side is about 25 millimeters of mercury. So theoretically, if you move up more than 25, a central retinal vein occlusion can occur in a susceptible person, and more than 45, you can get a central retinal artery occlusion. But practically, we don't see that. So for a longer period of time, if your pressures are like 60 or 65 or 70, then you may get CRVO or CRAO or ischemic optic neuropathy. So that is a thing that everybody has to consider whenever the bottle height is very, very high. Now the bottle height is high, and you have an open, you don't have a watertight chamber. Like for example, phaco wound is still a little bit leaky. Not like the vitrectomy where it's completely watertight. If it is watertight like a vitrectomy and you are putting the bottle up there, you are definitely going to have some problem. But in phaco, because of this leakage, sir, 40 millimeters bottle height is equal to 40 millimeters of mercury pressure.
110 bottle height. How much?
That is about 90 to 100 pressure. Yeah, that's not good.
That is much over 70.
Yeah, that is not good.
And most of the phaco surgeons put it at that.
But that is why I'm telling, sir, there will be some wound leak. There will be some blood which will be expelled through the sides of the wound in a phaco. So it may not be effectively 70, 80, 90 inside. That's point number one. Point number two, most of the phaco surgeons are now very, very rapid in their surgeries. In about 2-3 minutes, that phase is over. Okay. So if it's a novice surgeon learning for about 45 minutes to 1 hour, then we have a problem.
See, one time we even had a fish pump which is increasing the pressure of the bottle to get the pressure down. But we never heard of these incidents of...
Because we never looked for it, sir. So there are some patients in whom post-operatively visual recovery was not 100%. So we said, okay, this is there. But once we recognize this problem and when you look back at it, you will also see that there will be some cases like that.
So in fact, we are irrigating and aspirating at the same time. No, so
That is
that's
also-
why the
Movements in between,
the-
they're not keeping every instrument is out.
yeah,
Those movements he's
those more. Yes.
I'm not telling that every case
So-
will land up in that.
Yeah.
But we have to be, in predisposed cases, we have to be careful about it.
Yes, definitely.
The second question is, suppose you have a cortex fall into the vitreous cavity.
Cortex.
Cortex.
Yeah.
How much of cortex would you say if we don't touch it?
Yeah.
We let it
Yeah.
resolve?
Sir, about 20 years back, we would say that 25% of the cortex, if it is there, we will leave it there and give steroids, etc. That age is gone. That age is gone. Cortex inside will cause cystoid macular edema, will cause uveitis, will cause increase in intraocular pressure. Should be removed.
Any amount.
Agree.
Any amount.
And same for the nucleus, any piece.
Absolutely, because nucleus will induce IOP rise very, very high. Now, it's like, now because we have transformed from the 6/18 cataract surgery, 6/36 cataract surgery to 6/6, 6/6 parts cataract surgery, sir. So we can't leave cortex in the
A
vitreous.
small flake floats down in front of you through the gap. And you think such a small flake it will dissolve.
Yeah, it's a surgeon's philosophy, sir. So because let's think that this flake went down and dissolved, nothing happened, it's okay. But now I'm not telling that this small flake or speck, if it induces a cystoid macular edema tomorrow, then you'll have to do it, no?
No, but at the moment the surgeon has to take a decision. Do I call a vitreous guy in or should I let it be? It's a small flake.
The small flake that most of the cataract surgeons tell me, finally when I take out, ends up to be a very large flake. That also is a major problem. All right. So a small nucleus bit, about 50% of the nucleus will be inside.
No, any nucleus actually. A small flake, actually a small
Yeah,
flake.
cortex.
It's
I
just
actually got
cortex.
these strongly about cortex.
And it just in front of your eyes, it is just lift away and floated down. Not do you call
Maybe.
it vitreous
Okay,
or
sir,
something
for
like
bargaining sake, I will say that it's okay. It's okay then, let it be.
No, I think
Let us see the
Sanjay,
patient post-operatively. Will you tell the patient that the small nucleus, cortex flake is down? Will you tell the
but the
patient?
cortex, if you,
When you complain of floaters and something.
No, will you tell the patient?
no, I think Sanjay,
or no?
the important thing is like,
You will not tell the patient. And then if the patient comes back with floaters or cystoid macular edema, how are you going to talk to the patient?
Something that probably something has moved down and you call it retinal.
That is going to be a lie, right?
Going to be tricky.
Yeah, that's all.
Sanjay, I think it depends on whether you have the fragment is the nucleus or the cortex. Cortex generally, because if you are left with the small fleck of the cortex, it is get absorbed in a 3 to 4 days. I don't think there is any time to induce CME. But if it is a nuclear piece, it remains for a longer time. Then there is always a chances of
The
having the
quantity of the cortex is all important, sir.
the small fleck we are talking.
Yeah.
If it's a small fleck,
Yeah.
then I don't think there should be
Maybe.
much
Okay,
problem. Thank you very much. Thank you, Dr. Gopal,
you very
for
much,
the
sir.
nice
Thank you.
presentation. And now I'll call upon none other than Dr. Vanathi. Dr. Vanathi is the professor at RP Center AIMS, and she is our cornea and cataract surgeon, and she's going to talk on cataract and keratoplasty, very important subject. I think we must listen it properly. Thank you, Dr. Vanathi.
Thank you very much, sir, for your kind words. At the outset, I wish to thank the organizing committee for making me part of this wonderful session. So in the next 7 minutes, I'll take you through scenarios where we are going to deal with both cataract surgery and keratoplasty. So concerns when one has to deal with a cataract with a poor cornea or a bad cornea is when you look at a simultaneous cataract and keratoplasty, where you'll need stage procedures, or where the other concern is what is the IOL power you'll need to use for these corneas. Either you're doing it as simultaneous procedures or as stage procedures, and the postoperative management you would follow in these cases. So I'll just take you through a few case scenarios here. Triple procedure earlier on was just a PK triple, meaning you do a penetrating keratoplasty, combine it with a cataract extraction and an IOL implantation. But nowadays, we now moved it on to doing a phaco DSEC, doing an SICS DSEC, and of course, the latest is the phaco DMEC. So these are all the variations when you're managing cataract along with a poor corneal endothelium here. The question again arises, what is the type of IOL you would want to use in these cases, and would you use premium IOLs in these scenarios here? If you're doing stage procedures, the concern here would be which procedure you would do first, the time interval between the procedures, and what are the pros and cons for each of these scenarios here. So these are the questions which each surgeon will have to deal with when you are looking at these cases here. So here is quite a bad cornea here, and phaco has been completed here. The endothelium is poor, so we need to go on and do a DSEC surgery for this particular patient here. So you can see that phacoemulsification in these corneas definitely is a little more difficult here. But if you're able to do several times, you would probably need to bring your nucleus into the anterior chamber. And as you know, you're going to do an endothelial transplant, you would probably go ahead doing an anterior chamber phaco in these conditions. But beware, you would not want to damage the stroma when you're doing these. And please remember to remove all the viscoelastic material before you're proceeding on with a DSEC for an endothelial keratoplasty here. So there you see the desmoids being scored off, and with the aid of an intraoperative OCT microscope. These are quite challenging cases, especially when the visibility is not this good. Then you cannot do a DMEC for these, but you will want to do a DMEC for this procedure. So there is the lenticule is in, the main wound is then sutured up, and the lenticule is positioned with a complete airfill here. I think due to want of time, we will run through the next scenario here. Here you have another scenario of a case where the phaco has been completed in a case of Fuchs dystrophy. You can see the central cornea is quite bad here, with the endothelial gutty showing through here, and you go ahead and complete the DSEC in this scenario. So the question in such scenarios is, when would you want to do an endothelial transplant? So the cutoff which is recommended on review of literature is when you have the corneal thickness over a 650 microns here, and the visibility affords you to go ahead and do an endothelial transplant and an uneventful cataract surgery. Then probably these will be scenarios where we would look at doing a combined procedure as a single stage procedure here. And again, when your critical cell count is below 700, 800 cells here. That said and done, what we have in newest or latest in literature is the nomogram, which is given on base of pentacam tomographic indices, where you look at the posterior corneal curvature imaging, and this has a classification over which you would be able to prophesize if this Fuchs dystrophy is going to progress or not progress, and that is going to probably be probably going to tell you whether you can take up these cases for a cataract surgery along with an endothelial transplant, or these are going to be non-progressive types of Fuchs endothelial, and you could wait and watch in these cases here. Then when you do have very brown cataracts like this, and of course these are phacoable here, but if you would want to and if you find that you're not going to be and you're not going to end up with an uneventful phaco in these procedures, then we would go ahead and convert and do an SICS in this particular case. So you see the nucleus taken out, and you do have a slightly larger wound than you would have when you do a phaco DSEC, and that does help when you're planning endothelial keratoplasties, because you don't fold your lenticles too much and makes your insertion into the anterior chamber of the eye. Your lenticule goes in uneventfully without folding here. But I do sometimes choose a different site in this particular patient, because it was depending on the laterality and how deep sunken the eye is, and the ease of maneuvering and putting your lenticule inside will also help you to decide how you would want to place and position your incisions, get an airtight chamber to place your lenticule, so that you do not have you're free of any postoperative lenticule related problems in such scenarios here. So now we've seen a routine phaco DSEC, a phaco with an ultra thin DSEC here, an SICS DSEC here. So these are all variations on how you will manage, and this is a postoperative picture of the same patient here. In the first postoperative week here, a very rapid surgery in these, and really helps to visually rehabilitate these patients here. Another word of caution for cataract surgeons who are doing surgery following DSEC procedures here. Here you see at the end of the surgery, you could see here when my side port is hydrated, and all is not well. So an IOCT does reveal that when you do hydrate these side ports, you can inadvertently detach the DSEC which was adherent earlier, and that needs to be tackled immediately. Otherwise, you could dislodge the graft, and you would probably end up with a corneal decompensation. So that's one particular scenario here. I think use of toric IOLs here, if your surface regularity is good, and if you do not have a much of higher order aberrations here, sometimes you do go in and do use your toric IOLs here. This was one particular case where it was specifically a T8 here, and this is a happy patient for using 6/9, but that probably would not be there in all other other cases. I think because of lack of time, I won't take you through the other routine conventional triple procedures here, and I thank you for the opportunity to present to you. Thank you.
Thank you, Dr. Banati, for the beautiful presentation. I think a very important subject where many a times we come across the corneal problem and the cataract, we have to do the combined surgery. So you have very nicely explained what should be done and how to take up these cases. Thank you very much. Thank you. So I'll request now Dr. Harbans Lal. You all know Dr. Harbans is the proficient cataract surgeon. He's based in Delhi, and we do not need much introduction of him. And Dr. Harbans is going to talk on the topic is
Post-RK.
post-RK cataract surgery. Dr. Harbans.
So just one comment on the previous talk. If you are going to do the cataract surgery first and your patient might need the DSEC, maybe you leave the patient myopic by minus 0.75 minus 1, because this DSEC can increase the thickness and patient becomes hyperopic afterwards. So now I'll be coming on to my talk. This is more or less related to our cornea talk only. So when we are talking of the post-RK cataract surgery, I think the surgery is not so difficult because these are usually immature cataract, and the toughest part is choosing the correct IUL and whether to correct the cylindrical power or not. Just for those who have not seen the RK era, how the radial cut used to work, we used to give a paracentral incision leaving the central 3 millimeter. This paracentral incision was more than 90% deep, leaving descent and to the full length of the cornea. And with this, the paracentral area used to become weaker, and with the intraocular pressure, the paracentral area becomes steep, gets bulged upwards, and central area becomes flat, correcting the myopia. So all the fault which you get and this flattening which happens is not one time. This keeps on happening over the period of time throughout the life of the patient. That is the reason many a times you see the RK patients, they are highly hyperopic, +4, +5 diopter, and that is also a area of concern when you are doing a biometry. So this is what this happens, and not only this, these patients also have a diurnal fluctuations, a myopic shift in the morning and in the evening. You do the refraction in the morning, may be different in the evening, because at night time hypoxia to the cornea leads to the stromal thickening, and patient may be hyperopic at that time, and by evening he may become myopic. So just I'll show you 2-3 cases before I explain. So this is a 51-year-old male, RK 15 years back. Refraction was -4, -3.5 at 120 degree. So patient is still myopic. There were not too many incisions. There was no hyperopic shift. So this is very simple, straightforward case. And in this case, when we do the optical biometry, you can see the cylindrical is 3.78 at 75 degree. IUL power is coming 13.5 or 13. And when we see the pentacam, the cylindrical power is again around 3.7 degree at 3.7 diopter. So in this, when we put on this iulcalc.crs.org, where we calculate all these LASIK post-RK patients. So average IUL power was 11.37, minimum was 10.13, maximum was 13.56, which is matching with the IUL master or the lens star reading. And in this case, usually the pentacam is more reliable than any optical biometer. But in this case, the flattest reading was of the optical biometer, not the pentacam. Pentacam was 13.5, and the minimum which we were getting, 10.13, it is because of the pentacam reading which the IUL calc calculates. So IUL calc is nothing very super intelligent, artificial intelligent calculator. It just takes all the keratometric value of the pentacam IUL master, both the readings, and then puts on all the formulas which are available to the minimum and maximum and gives you the reading, whether it's by pentacam or by this formula, but that gives you the range. And in all these cases, patients I usually target -1. And in this case, because if you see the cylindrical power had excellent agreement in all the aspect, whether it's a refraction, a lens star reading, and a pentacam. So the cylindrical power correction was absolutely top on. I mean, there was absolutely no problem in correcting the astigmatism. And IOL power, I usually use -1 in all these cases because these patients mostly turned out to be hyperopic afterwards. When I feed -1 in IOL CAT, maximum I get is 15. So we go with the 15 diopter and we correct the cylindrical power of this patient. So they are very simple, straightforward case, no problem. So this is another case, 636. And you can see the optical biometer 6.25 diopter cylindrical power, and total power is 21 diopter. Pentacam is entirely different. So now once we do an IOL calc with the -1 and a 0. So -1, you see the maximum is coming 29 diopter now. From 21 on the optical biometer with a 0, now this is 29. And why it is so? Because the keratometric reading on a lens star was 36.61, which was much more steeper, and on the pentacam it was 32.5. So the flattest was on the pentacam, and the cylindrical power is 6.25. So we decided for the 21, but whether to correct the cylinder or not. So if you see that the biometric axis was 172, pentacam axis was 145. 10 degree this way or that way is okay, but this is a little too much of a difference. So all irregular cornea, whether it is because of the RK or any other region, whether it's a corneal scarring, the refraction is the key for correcting the cylindrical power. It is not the keratometry. It is what patient, because the cornea is so irregular, so whatever area he is seeing clear, whatever axis he is seeing clear is more important than any keratometric or pentacam value. So in irregular cornea, if you see the refraction was at 164 degree, 165 degree. So we went with the axis of the refraction. So in all these cases, refraction in irregular cornea, whether it's a post-keratoplasty, post-corneal scarring, post-RK, the refraction is very, very important because, and particularly patient is using the spectacles and you see the what axis he has been using throughout his life. Probably his vision is clearer in that axis. This is now another male. This is 32 incision, and look over here, this is a 37.50, 46.80, average is 41.6, and the power what we are getting is 10.5. And the IOL calc gave us the average 9.79, minimum 7.7, maximum 11.5. So we went for 12.5 and more than what the maximum was. And 3 weeks post-op, undilated AR reading was plus 13.5, plus 1.5 at 145 degree. Acceptance was +9, plus 4.5 at 140 degree. This is where this was the first case where I went wrong and then I started analyzing my patients. So what next? So only option is the IOL action. 1 month post-op surgery, we decided to go for IOL action. At that time, it was just my guess. I went for 27 diopter. First post-op day, patient vision was 624. 2 weeks post-surgery, prescribed him -2 with 2.5 and the vision improved to 612. So spherical equivalent was still plus 0.5. I mean, 12.5 to going from 27, and while the biometer was giving 10 diopter. Over scleral contact lens, he accepted -4.5. So I'll just give you one rough calculation method over here. Optical biometer, if you see, 1 diopter is equivalent to 0.67 at a refraction plane. If you see whenever there is a 20, 20.5, 21, you will see that it is the 2/3 which it is the refractive error you corrected at a spectral plane. So if this patient had, and the error over here was the 46.80 keratometric value, which was, we didn't measure the flattest, but actually we measured the steep cornea, which was paracentrally steepening over there. That was the region of mistake. And if you see the this calculation, if you take 1.5 factor, hyperopia of 2 diopter increases the IOL power by 3 diopter. So +9 plus 0.4 is 11.25. Multiplied by 1.5, we needed 17 diopter more than what we had already placed. So 12.5 plus 17 would have been 19.5 while we implanted 27. So this patient, whenever you have got a refractive surprise, if you get say +4, so if you are going to exchange the lens, increase the power by 6. If you get a +8, increase by 12. So that calculation and is very important. So Another is that whenever this was another patient who had a IUL power which was coming at between +2 and -6, so we planned for the secondary IUL. Post of reflection was +13. Secondary IUL of 26 diopter was implanted. This is again empirical, and all those who have done the CAM surgery for the cataract, we know that these patients, when we used to leave the aphakic, they needed +10.5, +10, and average emmetropic needs around 21 diopter of IUL inside the eye. So aphakia is usually double the power in the IUL than what is the aphakic correction. So we went for 26 diopter. So the another important point to keep in mind is that these patients may have a transient hyperopia. As we are talking that whenever you add a tissue or the corneal thickness is increased, patient becomes hyperopic. That means immediately after surgery, if you are getting a hyperopia, do not jump to the conclusion. And you keep on measuring the corneal thickness every 2 weeks. When the corneal thickness gets stabilized, refraction gets stabilized, only then you should think of the actions. Up to 4 diopter, 5 diopter of the transient hyperopia is possible in these patients. So I think the lessons learned is that the flattest keratometric value you need to use the AIOCMTC1 target reflection between -0.5 to -2. Any keratometric value above 40, probably you are measuring the paracentral, because average corneal keratometric value is 43, and the RK should cause the flattening. Usually you will get 37, 38 is fine, but if you are getting any reading above 40, and if you are getting 43, 44, 45, 46, 47, that means you are not measuring the flat area, you are measuring the steep area. Any metric value below 18, cross-check and recheck the K values. Until and unless patients, the refraction is on the myopic side, you are going to err. So normally a patient who is normal should have a 21 diopter. Any value below 18, until the patient is myopic, you have got to really cross-check your keratometric value. Most of these patients, if you do not understand anything about what I talked, put on anything IUL between 24 to 28, you will be more or less close to the emmetropia. So either because these patients need more than normal, and if you do not want to go beyond 28, so the average calculation will be most of these patients need between 24 to 28 diopter. Thank you very much for your kindness.
Thank you, sir. Thank you, sir. Now I'll request Dr. the chairman of this session, to present his technique of swing needle microcapsulotomy, a new technique to avert Argentinian flag sign. So, Dr. Salab Sinha is there? Yeah. Thanks. So, official time is almost up, actually.
Thank you very much.
He's still left with 2 presentations.
Yeah,
So
thank
I'll
you.
request
Thank you,
the
Dr.
people
Sharma.
from the
And,
next session to
The
please bear
topic
with
which
us.
I am going to talk about is the saving needle microcapsulotomy. We do not have any financial interest in the subject matter of this presentation. You all know that the intermittent pearly white cataracts have always been a challenge, and they present to us in a different form. It could be an intermittent soft immature cataract, intermittent mature white cataract, it could be intermittent hypermature white cataract, or it could be intermittent extreme the hypermature white cataracts. How you can classify them? You can take the help of the OCT images, and most of the time we could see that these cases can be classified with the presence of the fluid which is there in the capsular bag, the type of the nucleus, which could be the swollen and white nucleus, and these are the categories we can come across. The important point is, whatever is the type of the intermittent white cataract, they have a similar character of thin, fragile capsular bag and high interlenticular pressure. So what happens whenever you puncture these white cataract with any device, whether it's a needle or a sieving needle, you get a outburst of the fluid from the capsular bag. Now this outburst of the fluid is the problem, because when the outburst of the fluid is coming out, this gives a tension on the area where you have punctured. So that is the reason when there is a volcanic eruption of this fluid and eruption of the pressure, this tear tends to extend to the periphery and you get a Argentinian flag sign. This is what happens when you puncture these white cataract with a high interlenticular pressure. You just puncture, and the puncture which you have made on the capsule tends to extend to the periphery. So this is called as a Argentinian flag sign. This was described by the paranoid DM somewhere in 2000, and we all have seen in our clinical practice. And he said it's primarily because of the raised interlenticular pressure, could be because of many other reasons. And this was one of the most common complication, and we used to come across in our clinical practice, especially in the intermittent white cataract. And the incidence has been reported from 3.85 to 28.3%. So because of the complexity and the high incidence of this particular problem, several techniques have been described and devised, and people have come across with many of these techniques. One of these techniques, we call it puncture-axis, and so many things. And one of the commonly practiced technique is the small needle aspiration technique. We all practice this, but what happens even with the small needle aspiration technique also, many times, the moment you puncture the anterior capsule, the capsule starts extending to the periphery and turns into the Argentinian flag sign. So we had a presupposition that ideally it's not only the interlenticular pressure, there has to be some other factor which is responsible for the extension of the capsular tear to the periphery. We came out with this article in JCRS, and we have explained various theories. So I'm not going into the details of the theories, but what is important, what you need to see here is what happens when you puncture the capsule with the needle. What happens? You create a cut on the anterior capsule. So this is the cut. And this cut is the problem, because if you create a cut, and even with the capsular axis forceps also, when you start the capsular axis, you tear the capsule. So again, you are creating a linear cut on the capsule. Now this linear cut actually tends to extend to the periphery because of the high pressure. If you create a cut on the capsule, it's definitely going to extend to the periphery because of the interlenticular pressure and the outburst of the fluid. This is what happens normally. And if the hypothesis we came out was like, if we, instead of creating a cut on the anterior capsule of this kind, if we are able to create a hole on the anterior capsule, if you create a hole will have a more resistance against any kind of interlenticular pressure or the outburst of the pressure. If you have a hole will never extend, because it works like a micro rhexis we used to do earlier, mini rhexis. But in mini rhexis or micro rhexis also, you have to puncture with the needle or use the forceps, you create a cut, then you create the micro rhexis. But before you create a micro rhexis, your capsule starts extending to the periphery. So what happened, like we devised this, came out with this device which is called as the saving needle microcapsulotome. Now you see the tip of this capsulotome, it's round and pointed. It's a round and pointed, unlike the needle. So when you puncture the anterior capsule with this device, you will create a hole. Unlike when you puncture with this needle on the capsule, you create a cut. So there is a difference, clear-cut difference. If you puncture with the sieving needle, you create a hole. And if you puncture with the needle, you create a cut. So these are some of the videos where you can see how we do the sieving needle microcapsulotomy. You just puncture the anterior capsule, and you see the outburst of the fluid which comes out. And this outburst of the fluid is the problem actually, because as I said, it's the release of the pressure, the interlenticular pressure along with the fluid which comes out. And if you are able to create a hole on the anterior capsule, then this will never extend to the periphery. And then slowly you can evacuate the fluid out of the capsule and then start the capsular axis. Now you can create one or multiple punctures on the capsule. The multiple punctures have to be within 5 millimeter zone. It should not be beyond the 5 millimeter zone. That is important. And I'll just show you a few videos. Now this is the intumescent. I have some time?
I think you can wind up, please. Already.
Okay. I'll just show you one video, a minute, I think, probably. So this is one case. You see the puncture and see the outburst of the fluid. Now, if you are able to release the fluid from the capsular bag, then you are decompressing the bag, your anterior capsule becomes flat, and then you can very simply start the capsular axis. Another case, like you just go inside, But you have to keep this device vertically on the anterior surface. You have to puncture vertically, because if you are not keeping vertically, then you may tear the capsule. So idea is you should not tear the capsule, create a hole on the anterior capsule, and then you get the decompression of the back. And once you have the decompression, then you have to just go inside, tear that hole, and start the capsular axis. So to conclude, this technique is very simple and yet very highly effective. Adequate back decompression you get in all the cases when you puncture the anterior capsule, except where the cortex is semi-solid uh, or it's a solid kind, but then you not get the evacuation. But most of these cases have a fluid inside, and this will prevent the Argentinian flax. And thank you very much.
Thank you, sir. And I'll just request Dr. Salab Sinha to present his talk on traumatic cataract management. And I'll request him to be as short as possible, because we have already overstretched our time.
Okay.
Thank
Thank
you.
you. Thank you.
Actually,
thank you
we
to the-
started a little late. I think it was 15, 20 minutes late. We got the file. Yeah, nobody was here. So I think 10 minutes is okay.
Okay, the simpler traumatic cataract, you can see a scar here, a penetrating injury, and routine, side port incisions, staining with the trypan blue. And here is where the cutter can do your rhexis for you. I don't know why this is slightly unstable. So wherever there's going to be a scar in the cornea, and if the patient is coming a little late, there'll be anterior capsular fibrosis. You won't get a rhexis like you would normally have in your routine cataract surgeries, and your cutter can do your job. And it not only creates the anterior capsular rhexis, but also you can aspirate all the loose cortex. Generally, there's loose cortex, and you get a good enough opening. Sometimes it's tougher. So there's zonular dehiscence. I've removed the cataract, put in a CTR to take care of the zonular dehiscence. And then trying to enlarge the size of the opening in the anterior capsule, again using the cutter, and using the Y dialer, you can prevent any inadvertent injury to the iris. So the cutter can come handy. Then putting in the intraocular lens. Slight mistake on my part in this case. You will see that I should have tried to put the lens into the bag, but it didn't go in. So struggling. But here is where you can use a forceps. See, use a forceps and don't try to dial it, just try to place it using a forceps. Since the patient had a opening in the, had a PCO as well, went in and made a opening in the posterior capsule along with anterior vitrectomy. So next case, again, here after removing the cataract and putting in the lens, as you saw in the initial part, you have to also give good cosmesis to the patient. So your fourth row pupiloplasty technique can be used to give good cosmesis. So in traumatic cataracts, not only are you trying to remove the cataract and put in the intraocular lens, you're also trying to give a good cosmetic looking better eye to the patient. And you can see the end result that the pupil is round and looks better. And sometimes you need to, in certain cases, there is hardly any capsular support left. So you need to use these technique of intracellular fixation of the intraocular lens. Here you can see I'm using a 26 gauge needle using the Yamane technique. But in my hands, I think the glue dial technique works better than the Yamane. In this case, you saw that while I was trying to put in the haptic, the other haptic just came out. So again went in. Oops. Just stopped. Some issue with the hard disk, I think.
Can we,
Sorry.
can we wind up the
Yeah,
session, sir?
that was the last I was trying to show.
Thanks a lot. Thank you. Thanks everybody for coming in and joining us. And thank you the photo. Sure. I think we'll not restrict the chairpersons of the next session, and we can have a pick on the sides.